Hello, my name is Thomas Gross. I'm a senior partner at the orthopedic practice of Midlands Orthopedics in Columbia, South Carolina. I've been trained in orthopedic surgery, specialty of joint replacement, and my real interest is hip resurfacing. I've been involved in the development and perfection of the operation of hip resurfacing for nearly 25 years, and I've now performed more of these operations than anyone in North America.
So Dr. Gross, can you tell us a little bit about hip resurfacing?
Yes, certainly. Hip resurfacing is a better version of total hip replacement. Total hip replacement and hip resurfacing both started in the 1950s, and over time, hip resurfacing became the standard. It's the most common, the standard treatment of severe hip arthritis worldwide. The reason that total hip replacement became the standard is because implant manufacturing technology just was not good enough to make adequate hip resurfacing implants back in the 1950s and 60s. It's been tried over and over again, and every time the implant technology hasn't quite been good enough to make implants that are adequate for hip resurfacing. That all changed back in the mid-1990s when Harlan Amstutz in Los Angeles and Derek McMinn in Birmingham, England hit upon metal-on-metal resurfacing, and they were able to develop very thin metal bearings that were adequate for hip resurfacing. And that's when the operation really took off, and in my view has become now the superior way to replace a hip. At this point, the technology is adequate, more than adequate, to create a proper hip resurfacing implant. But the problem that still exists is that surgeon skill to implant these is not quite there. Surgeons have learned how to do hip replacement over all these years. It's trained in all the major academic centers where I was trained to do total hip replacement. But hip resurfacing is a much more complicated operation, and it's not being taught at the major academic centers, so you kind of have to learn it on your own, and you have to be dedicated to it for a long time to become good enough at it where you cross the point where it becomes better than a total hip replacement. But I've long crossed that threshold myself, and I'm trying to educate other surgeons and get them to that point too, because in the end, if we perform hip resurfacings on most people who have severe arthritis, we're going to have overall much better outcomes and fewer failures. So let's start with just what is the problem that we're trying to address when we try to address severe hip arthritis. I mean, everybody's got arthritis in lots of different joints. That just means joint pain. But severe arthritis, what that means is you've lost your cartilage surface. And if you lose your cartilage surface on both sides of the joint to the point where the bone is rubbing on the bone, then at that point, usually what we call conservative measures like taking anti-inflammatory medications, Tylenol, doing injections, all those sorts of things are not really adequate. When the cartilage is worn away and the hip is bone on bone, at that point, most people are symptomatic enough, are having enough problems where they need a joint replacement to solve their problem. And this model of the hip illustrates the problem. You can see the ball and the socket of the hip joint. Now, not everything is on here, but the main parts of the joint are pictured. You can see that there's a cartilage layer, which is denoted in white here, and then there's the area where the cartilage is worn away. You see, and this is a case of severe arthritis. If the cartilage is worn away to bone on both sides of the joint, the bone is now severely irritated, and that's what we call severe arthritis. This is the point when people need an operation to solve the problem. Medications don't adequately treat the symptoms. You're very limited if you have this kind of a hip and just try to take medications. You can live that way. People did before the 1950s, but they're very limited. They limp, they have a lot of pain, they can't do the things they want to do. And most people at some point in this process decide that they want to have an operation to fix it. So what are we fixing in the operation? We are trying to give the patients a new cartilage layer. And we should first say that there is no way to regrow that cartilage with any means. Stem cells have been popularized in the last 10 years, and the idea is that stem cells cause tissues to regenerate, and that maybe they might make cartilage regenerate. The problem is they don't. And they're very, very expensive form of treatment. They cost $5,000 to $10,000 to get an injection of stem cells, and there's no scientific evidence that they can regrow cartilage. So first of all, don't get caught in that money-eating trap. Unfortunately, the only way we can solve complete cartilage loss is with artificial parts. And the idea is that we have to remove bone from both sides of the joint, the remaining cartilage and socket, remaining cartilage and some bone from the socket, and we have to remove some bone from the femoral side as well, and then we need to fix implants to both sides. When the implants are fixed to the bone and they're moving against each other, that's when you get back a relatively pain-free joint. Now, needless to say, we're not creating normal hips because we're not just recreating the cartilage. We're putting in artificial parts, and there's sort of a penalty of going into the hip joint. You're going to go through some muscles and some ligaments, and yes, they do heal very well, but not perfectly. So no one who has a hip replacement of any type can expect a perfect joint, but if your hip joint is bad enough, then it's going to feel like a miracle. So in hip resurfacing, what we're doing is just removing the cartilage and bone of the socket, about 4 millimeters, and we're replacing it with a similar amount of metal. This is a hip resurfacing socket. It's got a rough coating for bone ingrowth. It's got a very smooth bearing surface. We're implanting this. It gets hammered in, the bone grows into this surface, and that becomes your new fake cartilage. When you rub on this, it doesn't irritate the bone anymore. So now you have to do that on the other side as well. So we have to take off a surface layer here, which is shown in this model. We drill a hole just for machining purposes, take off a surface, and replace it with a similar implant that is about 4 millimeters thick, has a rough coating for bone attachment. That's implanted, and then the hip is put back together again. So you can see in a hip resurfacing, what we're doing is addressing the problem of cartilage loss with artificial surfaces, and we're leaving the final hip in a near normal mechanical position. It looks a lot like the natural joint, except that now there's metal on the surfaces instead of cartilage.
So can you tell us the difference between hip resurfacing and hip replacement?
Yes, certainly. I've already explained to you the key principle that you need to understand about severe arthritis, and that is that it is a situation where there's complete cartilage loss and the bone is exposed and the bone is being irritated on both sides of the joint. And so both operations address that. On the socket side, you have to remove the remaining cartilage and some bone to get into good quality bone to implant the socket implant. And in a total hip, you would put a metal piece in that's like this. It's typically made out of titanium. It has a rough coating, we call a porous coating, that the bone can grow into. And this has to be prepared to a point where this implant can be very tightly pressed in there. We actually hammer it in. It wedges into the bone, that holds it temporarily. Bone grows into those rough surfaces. That takes about 6 months to a year to get completed. And once that's completed, then this is basically part of your skeleton. There's also in surgery a liner placed for the metal shells implanted, then a liner is placed into it. And so that's your new fake socket cartilage. And what you should understand is that this implant, because it's so thick, has the metal part and the plastic part, it ends up making a socket that's much smaller than your natural socket. And that's what drives what we have to do on the femur side, where we also have cartilage loss. We cannot just cut this head down enough because the neck is so fat, it won't fit into that socket anymore. So that is why we have to amputate the whole head and neck, and then remove bone from inside the canal as a soft bone, and you rasp it out, and you can put a stem into that with a rough coating, also usually a titanium stem. The bone grows into it. Then you would affix to that. Titanium doesn't work well for the bearing surface, either a cobalt chrome head or a ceramic head. And this just gets popped on, and there's different lengths so you can adjust tension, and that goes into the socket. So we have satisfied the principle that we have to remove bone from both sides, fixed an implant solidly to bone, and then the implants come together, and as the patient walks and moves, there's no bone rubbing on bone anymore. So the basic pain problem is solved. But this is far from a natural joint. It works extremely well. It's been the standard operations, since the 1950s for severe hip arthritis. But it's not it still has some problems. It's not perfect. And one of the problems is that the socket that you create is too small. You have not recreated the natural socket, and the consequence of that is hip instability. Now, there's lots of scientific work by surgeons that try to reduce the chance of instability, but we've really never totally solved the problem, because the basic problem is that the socket is too small. And when the socket is too small, when you go to extreme positions, it can lever off and come out of joint. That's called a dislocation. The only way to really solve the problem of dislocation is to recreate the natural bearing size of the hip. And the other problem with a total hip replacement is that even though this stem is well fixed into the femur, you still feel the stiffer metal stem because the bone flexes a little bit. We don't think its bone is flexing, but it does flex a little bit, and it moves, and the load of the patient's walking on it gets transmitted into the femur that is flexible, moves, and the stem's stiffer, and the femur is just not used to that. It's used to being loaded on the top of the head, and if it gets loaded down here, the result is that people notice it. And so when we ask our patients who have total hips, they're usually very satisfied with them, but about 30% of them do say they have a little bit of thigh pain. It's mild, insignificant, not a big deal, but it's not quite normal. They notice it. Unfortunately, in about 2 to 5% of people, they really notice it. They would say it's moderate to severe. The patients would classify that pain as that. Unfortunately, there's nothing you could do about that. They just have to get used to it, because that's the femur, the femoral stem, metal stem, loading the thigh, and for some reason, some people are more sensitive to that. The other problem that happens is that when people are extremely active. So most people who have total hips, the average age is 70, and most of them think that golfing and walking on the beach and playing with their grandkids is an active lifestyle. But the younger patient is more likely to want to do more vigorous activities that involve heavy labor, heavy lifting, and impact sports. Impact sports are really problematic, because when you pound that stem into the thigh really notices it. People can't really describe that. Say I try to run, my thigh hurts. They don't say that. They say, I can't run. That leg just doesn't go. It's because that stem is loading that thigh abnormally, and they just can't do really vigorous activities. So with a hip resurfacing, instead of putting in this thick set of components, after removing the exact same amount of bone on the socket, you're putting in a much thinner implant, and the exact size of the socket is recreated. That's going to solve the instability problem right there. It also allows us on the femur to just take a thin layer off and save the head and neck. And this little stem is in the neck. It doesn't load, it's smooth. The porous coating on the femur is where the bone grows into. That's where the loading occurs. It goes where the attachment is. So the stem is just to insert it. It's a tiny little stem. It doesn't go down into the femur, and it doesn't accept load. The load goes through this implant right to the top of the head, which is still under this implant. And then the load gets distributed. So not exactly like a normal hip, but a lot closer to the natural hip. Nobody gets thigh pain with a resurfacing as a result of that. And people can do extremely high levels of activity. People routinely run and play impact sports on these without any significant discomfort. So they're not totally normal. They distribute load a little bit different than the natural hip, but right now they're the closest thing we can get to a natural hip.